here's a story from The World.
About 8 million South Africans live with HIV/AIDS. That's more than any other country in the world. And it's been this way for a while. In 2003, then-President George W. Bush created a program, the President's Emergency Plan for AIDS Relief, or PEPFAR, to help fight the crisis. So it came as a jolt when U.S. officials recently announced they would end all remaining PEPFAR funding. Winnie Banyima, the head of the leading UN program on HIV/AIDS, warned those cuts will cost lives.
Taking it away is taking away life-saving support from the most vulnerable people.
She made that plea to a largely empty assembly hall yesterday at the opening of the UN high-level meeting on HIV/AIDS. To learn more about the impact on South Africa, we reached out to Helen Rees. She directs the Wits Reproductive Health and HIV Institute at the University of the Witwatersrand.
Well, we've already seen some withdrawal of funding. The PEPFAR funds that we received very generously from the American taxpayer since George Bush initiated this. Some of those PEPFAR funds were stopped already over a year ago, and they came through the US aid provision. What we still have are PEPFAR funds that come through a CDC provision, and those have been ongoing. With the withdrawal of the US aid funds, what we saw was a very sudden reduction in services for HIV, and South Africa has the highest number of people as a country living with HIV worldwide. And that already had a huge and sudden impact on access to services, on testing, on people staying in care and staying on antiretrovirals. And we're already concerned that we're seeing an increase in the number of people who are defaulting from treatment and the number of people who are accessing testing.
So the State Department, the U.S. State Department, emailed a statement to Reuters saying that PEPFAR was never intended to be permanent and that South Africa is, quote, a middle-income country and is more than capable of supporting its own health programs, end quote. What would you say to that?
I think worldwide, everyone is recognizing that some of these international global health grants have a purpose for a particular period of time. So I think that would be a fair comment to say, well, let's help countries be able to fund their own health services. That is a fair comment. But to do it so suddenly, and this was really felt across the whole of the African region, really just left people abandoned. I mean, services for some people we call in key populations of high incidence of HIV, those services were stopped overnight and people had nowhere to go. And we've seen this across the region. So it's the suddenness. And I think it's fair to say South Africa is a low middle income country, but it's got a huge disparity in wealth. So we have many, many people who are living in poverty, many, many people, and the health services struggle. If you do this suddenly, what you do is you suddenly and overnight deny people access to care, and you don't allow services to adjust and say, okay, how do we respond to this? And the other thing that we must realize is that low income countries absolutely struggle to fund health services, and that there really is a priority for high-income countries to think about what is their responsibility to global poverty and global health.
Just on South Africa and PEPFAR, there was a general understanding that with the elimination of USAID last summer, so went PEPFAR. But it seems like PEPFAR, like a lot of USAID's global health operations, got absorbed by the State Department. Did the State Department keep PEPFAR alive exclusively in South Africa? Like, how do you understand specifically South Africa's relationship to PEPFAR over the past year and today?
There were two streams of funding, and the one was kept alive and the one was suddenly stopped. And we saw the impact of the sudden stoppage from USAID. The one that was kept alive has been incredibly important because it has kept services going and it has kept people on treatment, and it has allowed us to identify. We have millions of people we haven't yet identified who are living with HIV. So it's allowed us to continue that.
Are there other wealthy countries that have stepped up with the same level of medical assistance as the PEPFAR program?
No one has come in the way that PEPFAR did to really support the HIV program, particularly in the African region. It was unique, and it was George Bush's legacy, and it changed the face of HIV in the African region. It changed the epidemic that we've had across this continent.
Helen, remind us who has been served by PEPFAR in South Africa and what has been public reaction to this news in those circles.
The way that PEPFAR worked in South Africa, there were different streams of activity. The main stream was to support the public health services with things like outreach services, finding people and testing them, with keeping people on treatment. This is what you have to do when you have an infectious disease like this, because if you have a lot of people living not on treatment, not only do they eventually become sick, and that's a burden on the health services, they get co-infections like TB, which is a further burden on the health services. But it also means that if you have more and more people living with HIV who are not on treatment, that the epidemic in the country just spreads, because you've got more people who are infectious. So the intervention in public health services was incredibly important because it helped us identify, get on treatment, and keep on treatment people living with HIV. In addition, the funds also helped us target the really highest risk groups, men who have sex with men, adolescent girls and young women. It would be sex workers. These are people at the highest risk of acquiring HIV, and it allowed us to really focus on those groups. And they're groups that are difficult to pull into services, but it allowed us to pull them into services.
Yeah, similar demographics to other countries with also high rates of HIV/AIDS. But what are the factors in South Africa that has made it the country with the largest population of people living with HIV/AIDS in the world?
If you remember back to the origins of HIV, it started within the MSM community.
Men having sex with men.
Yeah, men who have sex with men. And it started, it really came to prominence from the US and from people in communities in the US that were first affected by HIV. But in the African region, it was a heterosexual. It was men who have sex with women, women who have sex with men. It was driven mostly by that. And that was different to what we had seen in the Northern Hemisphere outbreaks. But for South Africa, what we also had when this started, if you remember, we stopped apartheid at roughly the same time as we saw the emergence of this HIV pandemic worldwide. And part of what apartheid did was that it separated men and women. It said men are going to be migrant laborers, they'll go to the mines, they'll go to the big cities, women will live in rural areas. So you had an sort of terrible recipe for spreading heterosexual disease, because men would have relationships in the cities, relationships with their wives at home. Then we saw the generation of women who became infected at a hugely high rate. We saw about 30% of girls by the time they were 25 having acquired HIV when PEPFAR started. And with that, we also saw the transmission of HIV from a pregnant woman to her child. So this was a terrible recipe that you threw HIV into, and you got this extraordinary explosion of the epidemic.
Yeah, that's really interesting. The end of PEPFAR in South Africa, I mean, it's not just about economics, is it? As a State Department email suggested with its note about South Africa, middle-income country, et cetera. We have heard comments from a U.S. State Department official and congressional aides saying the White House is also upset that South Africa is not reducing its partnership with Iran. It's upset with black economic empowerment policies in South Africa and the continuing, mostly exaggerated claims of hatred of Afrikaners. How have those subplots emerged in the conversations about PEPFAR in South Africa?
I mean, we understand that the geopolitics of the world have changed immensely and very rapidly in the last few years. And some of the accusations against South Africa from the current administration are simply not true. There isn't a white genocide against farmers, and there isn't a white genocide against Afrikaners. I mean, you only have to look at our rugby team to see that actually what we're seeing is more and more integration. And that is the characteristic that we want to see in South Africa. But the geopolitics being one thing, but to suddenly stop a massive program that is going to stop the resurgence of a really damaging outbreak. And it's not just damaging. I mean, the one thing I would say from a global health perspective, if we stop funding suddenly in this manner HIV services, what we are going to see in the African region are increasing numbers of people who are living with HIV whose immune system is compromised. We've already seen, for example, with the Mpox outbreak that occurred in the African region, that the people who got very sick and the people who died were people who were living with HIV who were immunocompromised. So if we're really concerned about pandemics, if we're really concerned about this emergence of new pathogens that are causing outbreaks, what you don't want to do is to allow a continent that is vulnerable to suddenly have an increase in number of people who have HIV but don't have access to treatment. That could be a world-changing situation if we get another outbreak, if we get another pathogen that causes either a regional, a continental, or a global outbreak. So I think that there are other things that people haven't thought about here that actually will affect global health and will affect the threats to things like pandemics.
So then the key question when it comes to HIV/AIDS in South Africa, what is the way forward, Helen?
Certainly after the US aid withdrawal, the National Department of Health has really tried to do as much as it can, as quickly as it can, to try and integrate the patients more strongly into the services and to strengthen the services. But the resources are inevitably going to be limited. You can't suddenly just summon up financial and human resources who are going to fill the gaps of thousands and thousands of healthcare workers who were supported by the PEPFAR program. So that is definitely an effort. But if you think about the key population programs, those literally were closed overnight. And that's going to be very difficult for any government, and particularly the South African government in the current economic climate. It cannot just say, well, we'll just take everything over that PEPFAR was doing. Their resources are simply not there. So we are going to see an impact, although the efforts are ongoing to try and bridge a gap. But it's going to take some time and it's going to be very difficult to do. And certainly we won't be able to replace everything that PEPFAR offered.
I was speaking there with Helen Rees. She directs the Wits of Reproductive Health and HIV Institute at the University of the Witwatersrand in South Africa.